Hello, everyone. It's my great pleasure today to welcome Laesa and Sharon to talk about their work exploring lived experience as data. So with that, I'll hand it over to both of you to introduce yourselves and jump right into the session.
You're muted, Sharon.
Thanks.
There we are.
Thanks, Pierre, for introducing us. Hi, everyone. I am Sharon. I am an assistant professor in the Faculty of Education at Simon Fraser University. I'm also a psychologist at BC Children's Hospital. I'm really excited to be here with Laesa, where we're going to talk about integrating lived expertise in a project that we will share with you focused on implementation science and patient-oriented research. I'm bringing in a personal lens as an immigrant settler and have an interest in understanding how people's sociocultural context shape their health and well-being. And so as part of that, I bring in an equity lens to my research and clinical work.
Thanks, Sharon. And yeah, as Pierre said, my name's Laesa Kim, and I am a parent partner in research. I've got a child with medical complexity who is my bridge to this work. And my experience raising her and meeting other families and communities that are connected to this world is really what fuels my interest and understanding of research for patients and for children with medical complexity, and just very interested in emphasizing the voice of the parents and the patients that experience care and translating that into the research that we do.
Laesa. So Laesa and I want to start off by acknowledging that we're speaking to you today on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations, on which our research team is located, where we learn, study, and work together. We also want to let you know that the project we're going to speak to today is funded by the Child Bright Network, and that we as presenters do not have any other personal conflicts of interest to disclose with you. So here is an overview of what we plan to cover with you today. To start us off, I want to highlight that this is a project called the Pain Pathway Study that's been conducted in collaboration with Child Bright Network, and I'll speak to the team and who was involved over the course of this work. On a personal note, I was a postdoctoral fellow working with Dr. Hal Seiden and Dr. Stephanie Glegg, who are the principal investigators of the project we're going to speak to. And so I will kind of highlight some of the work we've done together there. Then we will really put an emphasis in our talk today about what it has meant to integrate lived expertise in this study. And then we'll also share with you some of our own lessons learned and practical strategies that we want to offer to the audience about what we found to be effective, and hopefully you can take away with you in your own work in this field. So to get start us off, the pain pathway, what is this? It is a clinical tool that was developed by Dr. Hal Seiden and Tim Oberlander as part of what we call the phase one of this work. It is a tool that's been developed to assess pain and irritability for children with severe neurological impairments. The children with severe neurological impairments typically live with cognitive impairments, are not typically able to move on their own, have mobility impairments and limitations, and most above all, they're not able to verbally communicate where it hurts. And we rely a lot on parents and caregivers to be able to help us understand their experience with this pain and irritability that is oftentimes unexplained, and it's difficult to find and identify the source of this pain. This tool was developed and evaluated in a tertiary care context and in a randomized controlled trial. This work was conducted across 4 pediatric care centers across Alberta Children's, BC Children's, Hospital for Sick Children, and the Children's Healthcare of Eastern Ontario. So what we learned from the phase one part of this study was that the tool was found to be useful and considered a success in that there was a proportion of children with severe neurological impairment where their pain was identified and for some cases resolved. And perhaps most importantly, even for the cases where there was no resolution of pain and irritability, families reported that being on the pain pathway was a helpful experience because of the support they were receiving. What was unique, and we'll speak to later a bit more about, is the support of the study nurse in this project, as well as the team's involvement in advocating for the care of these families. And so with that, it brought us to phase two. This is the project that I joined the team as a postdoctoral fellow and continue to co-lead this project with Dr. Seiden, Dr. Glegg, and the rest of our team, including Laesa, where knowing what we learned from the RCT in phase one, we wanted to ask, well, can the pain pathway now be used in a community context? Can we offer this to pediatricians who work with children and families in the community? And will it also be equally as helpful for them in seeing these children that present with health complexity and most importantly, the pain and irritability presentation? So to do this work, we are conducting what we call a hybrid implementation and effectiveness trial. What it really means is that we're going to continue to explore the usefulness of this tool for children and families in managing pain and irritability. And we're also going to test and evaluate the strategies that we use to help support this rollout of the pain pathway. What are the factors or processes that's going to be helpful to support the success of this use by the pediatricians, which is the implementation arm. And so this has been a project that's been underway for the last 2 years. We are taking a multi-method approach. It's multi-stage, so we're kind of going through phase by phase. And we emphasize a patient-oriented research model, which Laesa will speak more to, and taking into consideration health equity needs of this group of children and families.
So patient-oriented research is something not unfamiliar to those that are involved with Child Bright Network. It's something that's promoted and embedded into all of the projects that are part of Child Bright. And so this isn't new to you. What we understand, what our team understands patient-oriented research to mean is to ensure that the research that we're doing is reflective of the people that it's caring for and created for them. So it's answering questions that are relevant to these patients and their families, and it's finding solutions to those questions or supports and care advocacy for policy changes and system changes that are supporting those families and their children and what they need. And this can mean patients directly that we're engaging with, but in this particular study, in this population of families, these children are nonverbal. And so we rely heavily on their parents and caregivers to understand the child's experience, the child's lived experience, because the parents in this case are the experts of their child's care and management of their care and understanding their pain experience. So we want to bring this question to you, and feel free to use the chat while I talk about this here. If you want to take a moment to reflect on your own lived experience and how that informs the research that you do, whether a current study that you're working on or all of the studies that you are a part of, who has lived experience? Are we just talking about parents and patients, or is there more to this question? And we really believe that lived experience is coming from all of us. I've met clinicians that tell me a story about their upbringing, and I'm like, oh, that really informs why you started research or why you're interested in this topic. And so everybody brings something from their lives to what they're working on. And we've discussed this as a study team, looking at the intersectionality of our understanding of who we are and the world that we interact with. So it could be where you're living, the geography of where you're living, and understanding the supports that are lacking or not in place, or it's maybe a language barrier that you once had at a location that you moved to. Perhaps you're a clinician scientist, so you have experience in the clinic and you're doing the research, and that also would inform what you're working on. So we really are looking at this not to just look at the patients and the families, but who else has experience on the research team that is bringing that to the work that we're doing and the questions that we're asking.
I'll let some of you, as you're thinking about what Laesa said, feel free to chime in or just take a moment to reflect. I think as Laesa shared what it means to bring lived expertise, and I know the two of us often reflect on this, the intersectionality has been key, to think about the fact that and recognize and honor that each of us bring lived expertise in many different ways. And yes, there's certain parts of our identities that can bring in this more maybe like proximity to some of the projects that we're speaking to and the needs, but also that intersection is where we find the richness of what people's perspectives come in with. So I do think that we're talking about patient-oriented research and the lived experience of this population of people that we're working with, but also, as Laesa said, like people bringing lived expertise in terms of their maybe it's social cultural background, but also maybe the geographic regions they live in the communities they come from, or sometimes it's about the accumulation of their experiences over the course of their life and what that kind of how that shapes people's worldviews and the belief systems that you bring into a project. Thank you for sharing. I'm seeing that it's different experiences that's being shared in the chat, both in terms of both personal and professional trajectories. Yeah, that's definitely an important intersection as well.
Thanks, Sharon. So lived expertise, who has informed with their own lived expertise our project and how have we engaged with them? So the first group that we'll talk about here is family partners. And so something that our research team does that is maybe a bit unique and perhaps growing with other research teams, but has been unique from my perspective and understanding is that we have parent partners or family partners that have been embedded in the research team. So that includes myself and another parent partner that are involved with the Sidon research team that's been working on the PIU phase 2 project. And having us involved in the day-to-day research activities helps guide research questions and processes. It's always having a sort of a patient parent consultant on board and available to guide the research studies that are ongoing. And the reason that this is valuable is that it helps center the parent voice or the patient voice in what's being studied. It emphasizes the value of that voice, and it's really empowering. It's empowered me to have a voice, to share from my lived experience, but also for me to be empowered to gather more parents and more experiences to the table. And so that's what we've aimed to do.
So with that foundation, this foundation in our team that Laesa's highlighted, we as the next step into our like launching this implementation project was actually to go back to phase 1. We wanted to engage with the research team that was part of phase 1 to understand what went really well when you were conducting this RCT and what didn't go so well. And what's your kind of general feedback about your experience being on this research study that can help inform this next phase of this work? And so what we did is we spoke to all the members of the phase 1 team. Again, just a reminder, that was the randomized control trial that was conducted across the 4 pediatric hospitals. So this included 5 clinicians that brought lived experience and expertise with providing care in complex pain and palliative care and caring for this population of children with severe neurological impairments and their families. And then also 7 nurses with similar background in terms of their experience providing care with this population of children and families. And so we interviewed them and asked them to give us some input about what it was like going through this project, and what are some thoughts they have for us. And what we learned, for example, was that, overall we heard the pain pathway was easy to follow, and that was helpful to guide their assessment and management of pain and irritability for children and families. they were very aware that parents were appreciative of this process of being involved and kind of engaging collaboratively in learning about the steps of going through the pain pathway. Things that the team offered us as feedback or things like considering limitations in time and resources. I know that's a common roadblock we hear in healthcare, but some of the input the team members were sharing with us that that's something that's going to look really different from the hospital into the community, and how are we going to take into account the difference in these kind of restraints in a completely different context. Um, as we shared with these team members about what our plan is to roll out the pain pathway in the community, they also told us, well, to keeping with that in mind, keeping the role of the study nurse and supporting the families over the course of their participation in the pain pathway was crucial. And so we're honoring that to kind of keeping in mind that, okay, let's explore this more and evaluate the role of the study nurse in phase two. And we'll speak more to that as well. And that overall, the members of the team really helped us they spoke to recognizing the need for a standardized approach to assessing and managing pain and irritability, and that the pain pathway can be a promising tool to offer that for clinicians in general. So in this case, our effort to try and engage with people with lived expertise are those that came from the phase one research team, and that can offer us input about what their experience was like, and that helped inform our research process.
Thanks, Sharon. And the Parent Monitoring Board. So the next group of experts that we look to engage with are parents themselves that have children with SNI and that have also moved through that pain pathway in phase one. So they've experienced the uncertainty caring for their child with pain, looking for care providers that can help them, and then joined that study and received that care through the pain pathway in phase one. So these parents bring a diverse perspective. We were very intentional about looking for diverse representation of families, geography, and where they're located throughout the province. One of them is even out of province and has experienced care in two different provinces. We have a dad on the team, so just and different ages of children, one that's aged out of pediatric care. So lots of diverse experiences in navigating healthcare and taking care of their children and managing their pain. And then to reduce barriers and create equitable opportunity for our parents in how that they engaged with us. We've really worked to create multiple different communication avenues in how we communicate with them, whether it's via email or phone calls or Zoom calls or follow up in any of those ways. And we've really tried to honor flexibility in scheduling at various points of the day that's best suited for our parent contributors. And then we've also created visual descriptions of the study process and concepts. So when we first engaged with parents in the parent monitoring board at the very beginning of our study, and when we were still creating the protocol, and they're reading the protocol so that they can give feedback on it, there was a lot of terms within there that were unknown to them and new. If you're brand new to research, it can be very overwhelming. So we created some visual descriptions and a glossary as well to just better describe what it was that we were talking about so that they could be set up for success in being able to offer feedback and contributions to that. And then we've also compensated parents for their time and expertise. And this really emphasizes that empowerment and value of families, that we're not tokenizing using their lived experience and their lived expertise, but that we're honoring that is valuable and an important part of our study and process. And I'll just leave you with this quote from one of our parent monitoring board members. Participation with the parent monitoring board brings with it a profound awareness that every patient experience and journey will differ, but what becomes the constant is our willingness to listen and learn from each other, a true catalyst for change. And it felt really great to hear that from a parent monitoring board member. And we hear from them and we've gathered feedback from them that they do feel like their contributions are being heard and that they're making a difference in the steps that we're taking to implement the pain pathway.
Thanks, Laesa. Corinne, I see your hand up.
Yes, I was just wondering if we could take a question. We have
Sure.
that in the chat.
Yeah.
Right. How did you come up with the name Parent Monitoring Board? Quite unique.
You know, honestly, I've actually wondered like why did we land on that name? And so sometimes it could be called like a parent advisory group. It could be, yeah, it could be called several different things, I think, that maybe mean the same thing. This group here, we created a terms of reference at the start of our engagement with these parents, and so we have a clear outline and description of what our study is, what we're asking the parents to be a part of, and what level of contribution we wanted from them, and also offering to them what the study team would be giving back to them, and as far as consistent communication and updates and opportunities to be involved in different aspects, whether it's the KM creation or future down the road presentations, maybe, and different things like that. So Parent Monitoring Board was just the name that came out, but it probably could be a variety of things. And I think the key is that it's just described well in some sort of way. And so we used a terms of reference, but that could look different as well. Just describing what the point of that group is and what purpose it serves.
And I would add that, what was really valuable for us in creating the terms of reference with the parent monitoring board and other people that bring lived expertise on our project is that we offer this collaborative discussion and brainstorming together. We didn't come up with the name and offered it, but it was like, let's figure
Yeah.
this out together. Is there's a preference for this? Or, we have, I'll talk about the clinician advisory board in the next slide, but that there was no preference there about what that name could look like for the group. But this we gave the families and our team a chance to figure this out together, and that's been kind of the key. And I would say that's been the key also in my experience with other projects as well. And kind of fun because then you don't know what name, it's a chance to kind of create what you represent and what that can mean for the team. So
And yes, thank you for adding that too, Annabetta, that it monitoring and board does signal more of a supervisory sort of role. So
yes.
we're not just coming to this group of parents and saying this is what we're doing, but we're coming to them with these are our ideas, this is our plan, this is what we think. What do you think? What direction should we go? And they've really helped guide and direct some of the decisions that we've made along the way for the study. Yeah.
So with the parent monitoring board, we alongside that, we also wanted to ensure that we are bringing in input from community pediatricians, those that are precisely the group of people we want to be working with for implementing the pain pathway. So then we reached out to 3 clinicians that brought expertise in providing complex care and managing pain and irritability for children with severe neurological impairments that were practicing in the community within BC. Um, this included individuals that are currently actively practicing, as well as those that have retired and meant that they brought decades of experience that they could speak to what it was like when they were in practice. And so, similar to the work with our parent monitoring board, we developed terms of reference to outline their roles and what they would be involved in terms of the activities on the studies. And we worked very closely with the clinicians to design our study protocol and get their feedback on the findings we were gathering along the way. Perhaps what has been the most unique and a crucial part of engaging with the clinician advisors is that one of the clinicians offered us the opportunity to conduct a site visit at their practice. And so this allowed a member of our team, myself, to be at the clinic to observe the day-to-day of what it's like to be a community pediatrician and to understand the clinic flow. And that really as a starting point, informed the foundation of what we could understand. Like, what do we need when we're trying to implement the pain pathway? What would that look like for a community pediatrician on a day-to-day? And so crucial for informing relevance and feasibility of our implementation plan. And as a next step to our engagement with the clinician advisors, something we wanted to highlight is that as we put together our implementation plan, part of that process is to secure accreditation for some of the education and training we want to offer clinicians. And so our clinician advisors may be involved as members of the scientific community to, again, speak to how this can inform the relevance and inform the professional development of these clinicians. So together, the Parent Monitoring Board and the clinician advisors really offered us this really great circle for offering input, consultation, brainstorming, and really hearing from those with lived expertise that they each bring to the study. Excuse me. Oh, all right, here we are. So as the first step of implementation in conducting this phase 2 project, we conducted a barriers and facilitators assessment. And what this meant was that it was our opportunity to speak then directly to the pediatricians that we would want to partner with in rolling out that pain pathway. This was our first step to understand what would be those key needs and also helpful things that can help the easy and successful uptake of using the pain pathway in the practice. And so to do this, we went through a process of engaging with 12 community pediatricians that are currently actively practicing across BC. They're generally well represented from northern BC to the island. And we asked them to complete an online survey followed by an individual interview. The interview was really our chance to discuss with the pediatricians, what are your needs? What would it look like if we were to offer you this tool to be used in your practice to manage pain and irritability for this population of children? How can we help you make this an easy, seamless experience? And how do we support the ease of uptake? Because that's our intent to explore, like, what are the factors that can influence implementation? And what we heard from these community pediatricians are some key priorities that came up, and I'll highlight them here. First, their pediatricians spoke to the importance of advancing their skill set in this area. We learned from this group of pediatricians that their skills and sense of confidence in managing pain and irritability for this population of children really varied. And so, people brought in their own experiences in working with the patients and families they saw, but they were very open to learning a more consistent and standardized guidance that can be offered to streamline the way that all clinicians were engaging with this population of children and families. Community pediatricians, as you all might know, are very busy, and there is a significant constraint with regards to their time and resources. And this came through in our interviews with them. So what we heard from the pediatricians that we're very mindful of is if we're going to offer this pain pathway as a resource to them in their practice, we want it to be easy to access, simple to understand, and visually organized in a way that can be readily available to them as soon as they're seeing a child that's presenting with pain and irritability. And so that's been something we're very mindful of as we're designing the ways in which the tool can be used by the pediatricians. The last one is keeping in mind the environmental context and the resources available in a community setting. We heard kind of unanimously from the pediatricians that the resource available and supports that are used in a community practice is strikingly different from what's available at a pediatric tertiary care setting for reasons why it's different levels of care being provided. But that being said, when they're seeing children that's presenting with pain and irritability, pediatricians talked about that they would welcome opportunities for networking with their peers who might have similar children that they're seeing in their practice, as well as a desire to engage in consultations with those who are considered experts in the field. And when we say experts, we mean those that bring experience with complex care, palliative care, pediatric pain, and, I know this whole presentation, at least in our covering, is about lived expertise. And so it is one thing to ask the pediatricians about their expertise in their community care, but then also hearing from them that they want to hear from other experts in the field. And so that's something else that we are mindful of in building into our implementation plan. I see a question.
Yeah, thank you so much, Sharon. And hoping this is a good time to pause because I did have a question for the team. I was just curious because, as you're speaking of, the ways that you've been engaging with these two main groups, and considering the lived experience piece and what they bring to the table, I was just curious if the team has consulted or plans to consult. We have two main network-wide knowledge mobilization hubs, one of them being a family hub and the other one being a clinician's hub. So I'm just wondering if this could be something that either the team has thought of exploring or will be exploring within the next little while as KM activities are being done. But, if that's something that you'd be willing to do, and then what these consultations might focus on.
Yeah, it's a great question. And a wonderful resource that Chowbright offers. When we developed our study protocol, we engaged with the Chowbright's Knowledge Mobilization Hub, as well as all the other hubs, in fact, like the EDIDI hub, and also the patient and family partner hub. And that was really comprehensive in getting us started, especially because we were just in the process of developing and assembling our parent monitoring board and clinician advisory board. So we were coming in kind of fresh as a research team trying to build those relationships. So engaging with the Child Bright networks were really helpful. Myself and another member of our team who's also on the call today are also members of the Clinician Hub in KM. So I kind of bring in that lens, being a member of the KM Hub as well as a research team that's kind of helped us straddle what expertise we know could be offered through these these hubs. And I think it's actually a great reminder now that you've brought that up that we want to continue to engage with these hubs as we progress. So I can envision that being checking in about how are we sharing preliminary findings, and also as we prepare to launch implementation, any further feedback on kind of our process. So it's a great idea. Okay. That brings us to kind of at this point, Laesa and I wanting to highlight some of our lessons learned, having engaged with these groups along the way of our implementation project. And also, so we want to share with you some of the reflections we've had, as well as hopefully offer some practical strategies that you might have heard already, but we'll summarize here.
Thanks, Sharon. Yeah, so we've learned a lot throughout this process, and I think are still learning as we're still ongoing and continuing with this study. And I can't actually believe that I would say this first one out loud, but embrace slow science. I think a lot of parent partners that first join research or somewhere in the first year or so realize how slowly everything moves, and it can feel very frustrating. But actually, the science that's going slow because it's taking time to build relationships and develop those processes intentionally and meaningfully is that's the science that we want to lean into. And so, yes, sometimes that can take a lot longer. It's a lot more work to send email updates to clinician advisors and parent monitoring board members and get feedback from everybody and then integrate the feedback and talk about it. It takes a lot more work and time. But the end result is that relationships are being developed and the outcome of the research is more meaningful and hopefully more effective and actually creating the change that we're hoping for it to create.
The second one we have is seek feedback early and often. I think I appreciate these lessons learned because it's a good reminder for myself too that, as Laesa says, building relationships and engaging in that process takes time. And with that, you can take advantage of that process and journey and engage with those all interested parties involved and ask for feedback. There's always opportunities for these more meaningful, deeper discussions and reflections, and where there can be opportunities to integrate that input into strengthening our research process, always and kind of continually. And so the questions we ask often are, and what's working and what's not? What are your thoughts about these preliminary findings or trends that we're seeing in the data we're gathering? because there's always also opportunities to fine tune and um, improve the methods we're using and the approaches we're taking. So I think that's another piece of feedback is don't be afraid to do that. And that means, if you want a concrete strategy about that, it does involve some scheduling and organization, right? That we're wanting to engage with families 4 times a year. What does that look like in our calendar in a given year? We want to mark that out, send out those calendar invites. Something that Laesa will speak to later is like how to make the research accessible, but just thinking about that there's different ways of engaging with your team members to get that feedback. It doesn't have to be very linear. So those are the ways that we've been trying to engage with getting feedback. And then I was just thinking if there's any questions. The next one is one that we want to highlight and we think about often is what don't we know? One of the things that is really something that I value and want to convey always in my work personally and professionally is that to engage in work that is inclusive and equity informed is an ongoing process. They're not boxes to check. When we designed the study protocol, when we wrote out the plan for how we're going to carry out this project, that was really intentionally thought out that the ways that we want to be inclusive to diverse voices, the ways we want to keep in mind what health equity considerations are for the children and families, for the clinicians that we're engaging with. We wanted to implement points of checking in if we're offering those opportunities and strategies over the course of the study. And so I think that's something that we offer that you want to keep in mind as a reflection. What don't we know? And have humility to that. Be open to perspective and experiences of others, and that there's always space for us to reflect on our own assumptions, which means that while there might be more time and effort being dedicated to refining ourselves, that also means that there's all these wonderful opportunities to really, as Laesa said earlier, make our work more inclusive, more equity informed along the way. So that's something we also want to offer is this kind of point of reflection on how to be bring humility into our work. It is that this is an ongoing process.
And finally, we have reflected on the different areas of the research study where we have needed to switch gears and readjust how we're presenting things or discussing things with different individuals that we're engaging with. And that's to make the research more accessible for them. So sometimes this is with the parent partners, maybe that don't have any experience with research and understanding some of the terms and words that we're using in protocols and things like that. And so it's better describing that for them. But also for the parents, it was helping them understand what implementation science looks like on a trajectory of a 2+ year project. And so we've done some visual representation as well to help them see visually what that looks like. And it helps them know where they fit in, where is their role in all of that. But this isn't just for parents either. We've also created infographics for the pediatricians that participated in our Barriers and Facilitators study. And we're trying to be mindful and thoughtful about what information does a community pediatrician need to know, what would they understand about research and why it's important, and how do we convey that back to them from the study that they engaged in. Because not every community doctor knows what research is about and how it's conducted. They don't all take that same interest as many of the clinician researchers that we work with. So we have to find a way to make that accessible and available to them as well. And when you make things accessible, and whether it's just easier to understand or reducing barriers in time commitments and when we meet with people and how we meet with people and how we communicate, that's really where you're able to bring in the most amount of people. And like to what Sharon is speaking about equity, it creates more equity and more space for more people to be involved than just assuming that whoever knows the terms already is somebody who can speak to it. So that's what we've learned, and that's what we're carrying from here. And I'm sure there will be more as we continue on. next stages are really leaning into implementing this pain pathway and the actual process of training pediatricians and getting this rolling out in the community practice. And so all the work of 2 years of all this slow science engagement is sort of reaching its peak at this point to get there.
And that wraps kind of where we are now with our project. What I will also add here is that this has been an endeavor by a large team of us, some of which are on the call. This has included folks from our phase 1 team and co-investigators, staff, and trainees, incredible trainees on our team that supported this project to date, and all of which has been led by Dr. Halside and Dr. Stephanie Glegg in phase 2. And so we just want to acknowledge all of their contributions and say thank you to them as well. Here, Laesa and I have provided our contact information, so please reach out. We are always happy to speak to our experiences and share ideas. And we also want to highlight, because we've been doing lots of outreach to share our work. Laesa and I recently completed a interview at it's called the As Per Usual podcast, where we spoke to about capturing parent voices in implementation research. So a greater emphasis on what it's like to engage the families in this work. So we welcome you to take a listen if you're interested in hearing more, but you can also just learn about our study in general more on our website, which is www.paindetectives.org. Thank you so much for having us. And we're happy to take questions now.
Great. So I will take it from here as Pierre has stepped away for his fatherly duties. I see that Animette has raised her hand. Go ahead.
Animetta, hi.
Yeah,
That's
I
okay.
don't disclose that like I'm on the study team too, so not like totally innocent questions here. But I have not heard your presentation here before, and it's really interesting to hear and reflect with you on that. So these are more like kind of reflections I have from hearing you talk. So first I was reminded, you asked about like what is lived experience or who has lived experience. And I was reminded how we have also, through this process, realized how lived experience can oftentimes intersect with other kinds of experiences, maybe professional experiences or skills. And that's something you can capitalize on, like your patient parent partner may also be a skilled graphic designer or your clinician partner may also be a caregiver to somebody and have that kind of experience. So I think that's something that is great to keep in mind, that lived experiences can come in many ways. And then the other thing I thought about, it's very interesting to hear you talk about embracing slow science, which we often see as this sort of like hassle or annoyance or, a negative of what we do or something, we even have to like excuse to people, oh, I'm just searching so long, blah, blah, blah. And so I thought that was really interesting perspective. And then it made me think also how, lived experience, that is something you built, like literally, it's like through your ongoing or, your experience over time. That's how lived experience is acquired. So we couldn't even get to that, use it, engage with it unless we had time, because it needs to come into existence for us to be able to even, engage with it. So I thought about that's a very good advice to shift this idea that it's a drawback to research, that it takes time, and say, oh, maybe actually it's not just a necessity, but also something that we can actually use to increase our knowledge and understanding and appreciate our processes. And so that also goes for knowledge, right? That I think that's something that we have learned, as you're talking about how we build relationships with, that's part of doing good engagement, is to really build these relationships. And that's also how we create knowledge. We build knowledge. It's not, we don't read one article and we have the answer to anything. That's not what our research looks like. That's not what a lot of research looks like. We ran the test and here's the result. That's just not what it looks like. And I think that we could really benefit from both appreciating that for ourselves, that sometimes our research results, if you like, are actually this kind of knowledge that and relationships that we build over time, to understand what we're doing and to understand the people that we're working with, and then also translate that to the people, or share that understanding with the people that we work with, that what we're looking to do is not to find the answer necessarily. It is as much to build our knowledge and experience together. So thank you for that. Yeah, that was.
Thank you so much, Anna-Mette. I just love your mind and the way that you think and that reflection. It's really, thank you.
Yeah, I think it's great to hear from you, like what you're taking away from that, because I absolutely agree. It's that accumulation of time and experience and interactions that we're building in. And there is a reason that's our number one takeaway. That's like top of the line of saying like embrace it. And that's been a strength of our project. And I think another thing to circle back to, for all of those who wants to integrate lived experience into their implementation research, here's how we did it, and here's what we kind of anchored on. And there are other ways to do it too, right? But I think, Anna-Mette, you spoke really well to like the essence of why this was our focus. So thanks.
So my question builds on the same conversation, but trying to look forward. You've got such this strong foundation. You've really built those relationships. So how do you think that will evolve, or some of the other opportunities that will come, particularly when you start to get into or to get more into the implementation where it gets super messy and all of those other elements. And I work in the sustainability and scale space, and as much as you want to develop some of those relationships, sometimes you have to answer something to be able to get a huge opportunity very rapidly. So once you've got some of that foundation, how do you think all of those pieces will kind of blend together as you continue to work?
It's a great question. I'm happy to start us off, Laesa. But
Yeah.
we're actually like really in the crux of it all. Because we spent, like I would say, this past really long period really trying to integrate, synthesize, like really massage in all the feedback we're getting over this last little while into these like next steps. Right. And as we're doing that, we're thinking about exactly what you're asking, Celia, which is like, what's next? As we launch implementation, what are those points of contact and checking ins we want to be doing and seamlessly kind of integrating feedback? So do I have an answer to that? I think we're planning ahead, like as part of what's been a great structure that we've established, is that, for example, we have our terms of reference, right? That means that we do annual check-ins about, okay, we've done this year's worth of work, and here are some milestones we've hit together as a team. What can we anticipate in the coming year? And to kind of map out what that looks like, and also then know when we're going to be ensuring those ongoing points of communication. I do think a practical strategy for everyone to can think about is how we have to stay organized and on top of that kind of planning. Otherwise, I do believe it can slip away from you, that it can be months before you're checking in with team members or keeping people up to date or getting feedback. So that's something more broadly I can speak to, but we're mindful of wanting to continue on building on the foundations we've had. Laesa, do you have anything you want to add to that?
Yeah, I just appreciate that you brought in the topic of sustainability. And so the idea of like, we're planning for this next step, but really the next step is just next year and what happens after that. And I think, yeah, what is that going to look like? And so, I mean, that's just reminding me that we need to start thinking about that as well as we're planning next year's next steps, but what's after that and how are patient voices going to continue to inform pediatricians and how they learn or what they're learning about and how to care for their children. Is there a way to continue that work beyond the study? Is there a way to continue the training beyond the study? And are any of the people that we've already engaged with going to help sort of champion that further in the community? Yeah.
That's great. Thank you so much. I just had a quick question as you were going through your lessons learned. I was just curious, because the inclusion, the equity piece is coming up in several projects and several areas. I was just curious about the work that's being done with the EDI/DI team we have at ChildBright, and if you've at least heard of or interacted with their health equity impact tracker, and just how that exercise has been for the project team.
Yeah, it's a great question. And also personal passion of mine. I think just as we've planned out and integrated how to incorporate lived expertise, we've kind of followed the same process for the health equity consideration. So maybe we can have a separate webinar on that. But the idea being when we designed this study, we thought about how are we bringing diverse voices and equity considerations into our research team? How are we bringing diversity and equity considerations into our project? And also how we're bringing the same things into the way we're sharing and translating information, right? So there's different levels of that we're thinking about. One example of that for us to doing that in our team is to offer reflections of what we've highlighted today, what lens we bring in from an intersectional lens into the team, and what voices are we hearing from. And those practices of reflexivity and positionality can help strengthen our team dynamics, but also what we're offering to collaborate on together. In terms of the research, what we're mindful of is understanding I'll call it the context, but really the social cultural context of the pediatricians that we're working with, and also of the families that we're going to be engaging with, right? Because that will inform the services that we're offering and also help us understand what disparities might be happening in their receipt of care and how that informs the strategies we're using to engage with them. So that's all kind of currently underway, but our plan is to put in points of evaluating these factors to see if we're actually hitting at least a consideration of people's demographics, especially as we're doing this as a provincial study. There's a vast demographic we're thinking about provincially, regionally, and in terms of the health services they're being offered across different health authorities too. And never mind also you think about sociocultural and linguistic barriers that families might be facing. So things that we're keeping in mind. And lastly, on terms of the knowledge mobilization, that's been something we've been very intentional about. So, Laesa pointed out, we're engaging with families and the public about the research we're doing, but how? So this might be one way of engaging, but what about when we create an infographic that can summarize visually what we've found, but also when we created that glossary, because we recognize implementation science and the language we use in research can be really difficult and obscure to understand. So how can we make that more understandable and break it down into more lay terms? So things like that again keeps in mind how we can be more inclusive. There's always more space to build more inclusive ways, but that's just some examples.
That's great to hear. Thank you so much. I don't see any more questions. I'm just going to turn it over if there wasn't anything else. Pierre, you want to round us out?
Both thanks so much to both you, Lisa and Sharon, for sharing your project with us and your experience in working with PWLEs. Yeah, great to hear. Looking forward to see more where the project goes. And yeah, so just to wrap things up real quick, I just wanted to just flag two other just upcoming networking session that is happening today and next month. So if you are free, interested to connect with other ChildBright folks, feel free to join. I'll add the link in the chat. But at the same time, if you have any feedback for us around any future training sessions you want us to hold or topics you think would be of interest for us to try and explore, feel free to fill out the provided survey link, and we'll be happy to start working on those topics. So again, both much thanks to both you, Lisa and Sharon. I hope you all enjoy the rest of your afternoon. And if it's not snowing where you are, enjoy the weather you have.
Thank you
Thank
so
you so
much.
much for having us.
Take care. Bye bye.
Thank you. Bye.
Bye.